and gentlemen. Welcome once again to another interesting live webinar under the aegis of Mumbai Hematology Group. And we are extremely proud to you another interesting episode. We are extremely grateful, and I would like to give a warm welcome to all the delegates, the expert discussants, and our keynote speaker. And I would also like to welcome our program director, Professor Dr. M.B. Agarwal, sir, President, Mumbai Hematology Group. We know him very well, Professor and Head Department of Hematology at prestigious Bombay Hospital, Leelavati Hospital, and Rich Candy Hospital as well. Inspiration for us, teacher of teachers. India is fortunate to have him, who has enriched us by collaborating with various stalwarts across the globe and bringing them on the virtual platform practically every weekend. No wonder, sir, that you have been awarded a lot of accolades, including the Inspiring Hematologist of India Award. May I request Professor Dr. M.B. Agarwal, sir, to take it forward from here.
Thank you, Dr. Manoj. Good evening to everybody in India, and good morning, good afternoon for the rest of the guys from the rest of the world. Today's guest speaker is Dr. George Castillo from Dana-Farber. He will be lecturing on Waldenstrom macroglobulinemia. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS for continuously supporting our academic activities. Mr. Yash and Kalpesh and their team from Perfect Square for flawless management of these webinars. Executive Committee of Mumbai Hematology Group. Of course, our guest speaker, Dr. George Castillo. All our discussants were themselves quite eminent hematologists or medical oncologists from India and across the globe virtually. And you participants for sparing your Saturday evening, morning, or afternoon. Tomorrow morning at 11:30, we have Dr. Nicholas speaking to us on CNS lymphoma, and that will be at IST 11:30 and UK 7 a.m. Our discussants today have been displayed here alphabetically. We have got 14 of them from all across the country. Abhijit Baheti, Dinanath Mangeshkar Hospital, Pune. Advaita Gore, Prince Ali Khan Hospital, Mumbai. Akshaya Mandloi from Suraksha Diagnostics, Kolkata. Amrita Chakrabarti from Max Hospital, Delhi. Dr. Bhausai Bagal from Tata Memorial Hospital, Mumbai. Dr. Deepesh Lad from PGI, Chandigarh. Dr. Govind Patel from SN Medical College, Jodhpur. Dr. Mona Vijayaran from Sahara Hospital, Lucknow. Dr. Aditya Murli from Esther CMI Hospital, Bangalore. Dr. Pranta Chakrabarti, Director Hematology, PMT Amri Hospital, Consultant Hematologist, Vivekanand Institute, and Senior Consultant, Center for Digital Healthcare, Kolkata. Dr. Reshma Roshan, Assistant Professor at Sher Kashmir Institute, Srinagar, Jammu and Kashmir. Dr. Shilpa Prabhu from Narayana Hridayalaya, NH Health City, Bangalore. Dr. Soumya Mukherjee from Apollo Hospital, Kolkata. Dr. Shweta Lankad from Avinash Cancer Clinic, Pune. Now it's my pleasure to introduce our guest speaker for the day. You have heard him before. We've been very fortunate in getting a lot of knowledge in the field of Waldenstrom macroglobulinemia from him. He was our guest speaker 6 months ago, and you flooded with me with emails of appreciation. You wanted to listen to him again, and you obliged us by accepting this invitation. He's clinical director, Bing Center for Waldenstrom macroglobulinemia, Division of Hematological Malignancies at Dana-Farber, Associate Professor at Harvard Medical School, Boston. He was born in Peru, received his medical degree in Mexico, completed his internal medicine, hematology, and oncology training at the University of Massachusetts and Brown University. The Waldenstrom macroglobulinemia clinic has seen more than 4,000 patients of this disorder during the last decade. You can understand the amount of experience he has is unparalleled. He's the principal investigator in a series of innovative clinical trials evaluating non-chemotherapeutic approaches for patients of Waldenstrom macroglobulinemia, and that will be one of the key part of his presentation today. He's a member of the NCCN Committee for Myeloma, Amyloidosis, and Waldenstrom. He's authored more than 275 peer-reviewed articles and has published his research in the prestigious journals like NEJM, JCO, Lancet Oncology, and Blood. We are really very happy and proud to have him today as our guest speaker, and he's going to teach us about Waldenstrom macroglobulinemia. Thank you so much, and over to you, sir.
Thank you very much, Dr. Agarwal, and thank you very much for the kind invitation to allow me to speak to such a nice, fine group of hematologists in India and obviously in other parts of the world as well. So I'm going to share my screen, and we will proceed with the presentation. So today I'm going to be talking about the management of Waldenstrom's macroglobulinemia in 2022. This is my email address is down there. As you can see, jorge.j_castillo@dfci.harvard.edu. If you like the slides, if you have a question about a patient, you have any questions about anything you would like that you think I can help you with, please do not hesitate on contacting me, and I'll be happy to get back to you. These are my disclosures. I'm going to leave this there for just a few seconds. So there are a few objectives for the lecture today, and one of them will be to determine the criteria for the diagnosis of Waldenstrom's. We'll explain the rationale for monitoring of asymptomatic patients with Waldenstrom's, and we will then appraise the multiple treatment options for these patients, including new agents and combinations upcoming in clinical trials. So one of the first questions that comes to my mind when I see a patient in my clinic, I'm very interested in knowing if a patient actually has Waldenstrom's macroglobulinemia. I would say years ago, it wouldn't really matter if you had a small B-cell lymphoma of some kind, as most of the treatments were very uniform and the responses great. The response rates were very uniform between them as well. But over the last several years, I think there have been clear distinctions in terms of how targeted agents do work in different subtypes of small cell lymphomas. So when a patient comes to see me, I really want to know, I want to make sure that the patient has Waldenstrom's. And I'm using these three criteria that you can see on the screen. I want to be very clear that none of these criteria on its own is diagnostic of Waldenstrom's. But if you put all of the three together, I think the likelihood that a patient has Waldenstrom's is very high. The first one almost always is the presence of an IgM monoclonal protein that is detected in an SPEP and an immunofixation. So there are other conditions that can have an IgM paraprotein, and the most common one will be MGUS, which is a benign condition. There are other lymphomas that can also have IgM secretion, and marginal zone lymphoma can secrete IgM in up to 20% of the times. CLL, smaller proportion. Even the very rare IgM myeloma can have an IgM paraprotein as well. So again, alone is not diagnostic of Waldenstrom's. Once we have an IgM paraprotein detected that is monoclonal, the next step is looking into the bone marrow of these patients. And what we will see in a patient with Waldenstrom's is a lymphoplasmacytic lymphoma. It's a B-cell lymphoma with plasmacytic differentiation. Now, lymphoplasmacytic lymphoma per se, it's a little bit tricky. And marginal zone lymphoma can have lymphoplasmacytic features, and even IgM myeloma can have lymphoplasmacytic features, just pathologically speaking. So I want to emphasize the diagnosis of Waldenstrom's is clinical pathological. We use clinical features and pathological features to make the diagnosis. Just to complicate things a little bit more, lymphoplasmacytic lymphoma patients can actually secrete other proteins that are not IgM, IgG, IgA, kappa, lambda, and there are some rare cases of non-secretory lymphoplasmacytic lymphoma. Now, those non-IgM LPLs are not Waldenstrom's. Now, they should be treated like Waldenstrom's, and those are the current guidelines by the International Workshop as well as the NCCN, but they are not considered Waldenstrom's. And therefore, the sole presence of a B-cell lymphoma with plasmacytic differentiation in the marrow is not diagnostic of Waldenstrom's itself. The last feature, which is a recent addition to the armamentarium of diagnostic tools, is the presence of the mutation in MYD88, specifically the mutation L265P. These mutations can be detected by allele-specific PCR testing, or more recently with this multi-gene next generation sequencing panels that we are using more and more here in the United States. Now, PCR testing tend to be deeper, tend to have a higher sensitivity rate, maybe 1 in 1,000 compared to an NGS, which is probably about 1%. So we need to understand the depth of the sensitivity of the test that we're using for this diagnosis. Again, MYD88 mutations can be seen in other conditions. As you know, MYD88 was initially described in aggressive lymphomas in about 20 to 30% of the cases. In CLL and marginal zone lymphoma, 5 to 10% of the cases can have MYD88 mutations. MGUS patients, 50 to 60% can have MYD88 mutations. So again, none of these criteria are diagnostic, alone, but the three of them put together, if a patient has an IgM paraprotein, a lymphoplasmacytic lymphoma in the marrow, and a MYD88 mutation, I think the likelihood that a patient has Waldenstrom's is very well over 99%. And that's usually the first step that I take in my clinic. Now, MYD88 mutations were described in Waldenstrom's initially in 2012. Stephen Trion from our research laboratory made this discovery in 2012. And as you can see here on the left, 265 are probably 98% of all the MYD88 mutations described in Waldenstrom's. But there are about 2% of patients can have mutations in other spots that are not 265. And classically, we have seen 219, 232, and 243. Now, this is tricky because the PCR and the NGS testing that we use to detect these mutations will not detect mutations outside of 265. So if we are suspecting a patient might have MYD88 mutations, but they are not positive for 265, and this is what we do at Dana-Farber, we sequence the entire MYD88 gene. I understand that that is not possible in other centers that do not have research capabilities. Now, Dr. Liang Zhu from our group developed the PCR probes that everybody uses now. And using that PCR in our practice, we have genotyped probably about 1,800 patients with Waldenstrom's. About 93% of those patients will have a mutation in 265. Other groups from other centers in Europe, in Asia, and there's a recent study from Latin America that will be coming up shortly, also showed that the prevalence of MYD88 mutations is very high in patients with Waldenstrom's. And therefore, I think it's reasonable to use this marker as a diagnostic marker in patients with Waldenstrom's. Now, just to give an example, in IgM myeloma, there are no MYD88 mutations, right? So I think it's, in a situation in which we do not know if this is clinically speaking a myeloma or a Waldenstrom's, having the MYD88 mutation will lead us to the proper diagnosis of these patients. Now, there's a second group of mutations that we have detected as well. Dr. Zach Hunter from our group did a whole genome sequencing and found these recurrent mutations in CXCR4, and this was in about 27% of the patients that we evaluated initially. And the CXCR4 mutations are a little bit more difficult to identify because we do have nonsense mutations and we have frameshift mutations, and there have been even some missense mutations that, detected. And for the nonsense mutations at Dana-Farber in our research lab, we have been able to develop PCR probes, and Dr. Liang Zhu published that when we use PCR probes for the nonsense mutations and do then Sanger sequencing for the frameshift mutations, the prevalence of CXCR4 mutations go up to 40% in our database. And again, we have tested about 1,800 patients with Waldenstrom's. Other groups from the United States and Europe and Asia have also shown a high prevalence of CXCR4 mutations in patients with Waldenstrom's as well. Then why is that? Why is this important? And we will talk about that in a second. The manifestations of Waldenstrom's are very diverse. And I would say in my clinic, and this could be different in other parts of the world, in my clinic, about 30% of the patients are asymptomatic at diagnosis. However, of those patients who are asymptomatic, a large majority will become symptomatic because of the disease at some point in the course of their condition. Now, when we think about the symptoms that a patient with Waldenstrom's do manifest, the most common manifestation of Waldenstrom's is anemia and the symptoms related to anemia, fatigue, tiredness, shortness of breath, and things like that. Now, this anemia could occur because of bone marrow replacement, which is the most common cause, but also we could have some iron deficiency mediated by an over-secretion of hepcidin, which mimics an anemia of chronic inflammation. There is also hemolysis, and cold agglutinins could be seen, as well as warm autoimmune antibodies. Thrombocytopenia is less common and occurs usually second after the anemia occurs first. And leukopenia is very rare, and that almost occur much later on in the disease process. Hyperviscosity is a classic manifestation of Waldenstrom's. About 15% of patients in my clinic do present with hyperviscosity syndrome. These patients do have recurrent nosebleeds. They do have almost daily headaches, and they do have blurred vision that is usually driven by changes in the retinal vessels. And these changes could be engorgement, they could be tortuosity of the vessels, they could be sausage linking or carboxing, as some people call it, and can even be actual hemorrhages in the retinas. All these caused by hyperviscosity. These patients classically need to be treated with plasmapheresis and then proceed into therapy afterwards. Neuropathy is another classic presentation of Waldenstrom's. This neuropathy is typically sensory, bilateral, symmetrical, progresses very slowly, but importantly is length dependent, which means the longer nerves will be affected first, and that means the toes and the feet are affected before the hands are affected. When the neuropathy advances to involve the knees, that's when the fingertips start getting affected. It has to do with the length of the nerve. So that really helps us to differentiate from other neuropathies that can be seen, such as amyloidosis or diabetes or B12 deficiencies. Other manifestations of Waldenstrom's include cryoglobulin disease. AL or light chain amyloidosis can complicate 5% of the cases with Waldenstrom's as well. We can see renal involvement, which is very rare, much more common in myeloma, but rare in Waldenstrom's, but we can see it. Pleural effusions, Bing-Neal syndrome, which is the involvement of the brain and the spine by Waldenstrom's macroglobulinemia as well, is also rare, but we can also be seen. As you can see, there's a wide diversity of clinical features in patients with Waldenstrom's. Now, this is where we tie in the biology of the disease with the clinical aspects of the disease too. So from our research and others, we have been able to understand that there are different genomic profiles of patients with Waldenstrom's. The most common one is the presence of the MYD88 mutation, but without CXCR4 mutations. That is actually 50 to 60% of the patients in our clinic will have that profile. We do have the double mutated patients, the MYD88 and CXCR4 mutations. That's about 30 to 40% of the patients fall within that profile. And then we have a smaller group of MYD88 wild type, CXCR4 wild type, meaning no mutations in MYD88 or CXCR4. That's a smaller group, 5 to 10% of the patients. There's a fourth group that I'm not putting here, which is MYD88 wild type, CXCR4 mutated. We have found maybe a handful of those patients in our clinic, so it's not very relevant clinically speaking. So when we looked at the clinical features of the different genomic groups, we do see that there are some differences here. For example, in the CXCR4 mutation group, we have a higher degree of OMR involvements, higher IgM levels, compared to the patients without CXCR4 mutations. And also, because of that, these patients have more likely to present with hyperviscosity and with acquired von Willebrand's disease, which is a coagulopathy sometimes associated with Waldenstrom's. We see it in about 5% of the cases as well. On the other hand, the smaller group without MYD88 or CXCR4 mutations, they tend to have a higher degree of lymphadenopathy. And there's a number of studies have shown they have actually a higher risk of transforming into a diffuse large B-cell lymphoma. So there are some clinical features that correlate with biology, and that's an interesting finding that we saw. Now, I think one of the important messages from this lecture is that we should not treat everybody at the time of diagnosis. And the question is, why not? And there are many reasons. And number one, we are not curing Waldenstrom's at this time. I mean, if we were curing Waldenstrom's, we would have a completely different conversation. On the other hand, I do not believe that in most cases, our treatments prolong the patient's survival. There have been a very few randomized studies in patients with Waldenstrom's, and overall survival has not been modified by any intervention. And for those reasons, if we're not going to prolong a patient's survival, then there's not a reason to treat for that reason either. In addition to all that, our treatments, although they are very good, as we will see in a minute, they do have toxicity, side effects, and they do promote resistance, right? So if we're treating a disease that we're not going to cure, when that disease relapses in the future, it's going to have additional features that are going to make it more difficult to treat as time goes by. So for all those reasons, I think if we have a patient with Waldenstrom's who is asymptomatic, I think it's better to leave this patient untreated. Now, there's a recent study by the Mayo Clinic in which they matched, based on age, sex, and race, patients with Waldenstrom's with individuals without Waldenstrom's. And as long as the patient remains untreated and smoldering, the patient has a normal life expectancy. So an additional reason in my mind not to treat these patients. We did this study, however, in which we put together about 400 and some patients with Waldenstrom's who were asymptomatic at the time of diagnosis. And we followed those patients over time to see the incidence, the probability of progression to need therapy. And within 2 years, about 30% of these patients would need to be treated. And then this curve kind of flattens out a little bit. And at the 10-year mark, about 80% of patients would have been treated. That means that if a patient is diagnosed asymptomatic, 20% of those patients, that's 1 in 5, will not need treatment for longer than 10 years. Another reason to leave your patients untreated if they are essentially asymptomatic. Now, we have developed a risk calculator and to be able to use specific clinical features or clinical pathological features to predict who might progress faster or not to need therapy. And this is something you can access online. It's a website, is awmrisk.com. And as you can see here, there are 4 different values that you need to enter. One of them is bone marrow infiltration in the bone marrow biopsy. In this case, I put a 40%, it's an example, 40%. IgM levels in milligrams per deciliter, in this case is 3,500. Beta-2 microglobulin level at milligrams per liter, which is 2.5 in this example, and albumin level in grams per deciliter, that's 4. Then you click, calculate the risk score, and then you will have the results on the right side of the screen. And we will have then 3 groups, potential groups, the low risk, the medium risk, and the high risk patients. In this case, a patient with these numbers will have a medium risk category, and therefore the median time to progression will be about 4.8 years. Now, I want to emphasize that these values should be taken around the same time. So you should not be using a bone marrow infiltration from 2015 and an IgM level from 2020. That is not fair. Have to be taken all around the same time. In the study, we actually showed that patients with low risk disease, the median time to therapy was about 9 years. The intermediate, as you know, is 4.8 years. In the high risk group, the median time to therapy was about 2 years. So based on all this, if a patient has low risk disease and is asymptomatic, I usually see those patients once a year. If the patient is intermediate, I see them every 6 months. If the patient is a high risk, I see them every 3 months. And that has been will be recently adopted by the NCCN recommendations coming up next. Now, we have gotten to a point in which we have followed our patients, we have given the chance of, not to be treated, and the patient has gotten to a point in which they need to be treated. These patients usually are anemic, they have hyperviscosity or neuropathy or any of the other symptoms that we mentioned. I think the key word here is the development of symptomatic disease in which the symptoms are affecting the patient's quality of life or activities of the daily living. I think those patients need to be considered for treatment options. And, we have multiple treatment options, and all of them are extremely effective. I want to start by talking about chemoimmunotherapy because I think this is what is number one used for the longest. So we have a longer track record with these. And number two, because I think the availability of chemoimmunotherapy outside of the United States is pretty much open and wide. So when I visit my colleagues in Latin America and when I go even to Europe, chemoimmunotherapy remains one of the most commonly used therapies in patients with Waldenstrom's. And this is in this table, we understand why. In this table, we have alkylating agents, cyclophosphamide, bendamustine. We have nucleoside analogs like fludarabine and cladribine. And the overall response rates are amazing, 70 to 90% response rates. The major response rates, which is a decrease in the IgM levels by at least 50%, is between 50 and 80%. And the progression-free survivals can be measured in years, 3, 4, up to 6 years in most recent data. Now, all these regimens are currently approved by the NCCN, not formally approved by the FDA, but approved by the NCCN in terms of category 2A for the treatment of patients with Waldenstrom's. Now, despite the efficacy, the treatments have side effects. And chemotherapy per se has a high risk or a higher risk of myeloid neoplasms, right? Myelodysplasia or acute myeloid leukemia. It's much lower with alkylating agents, about 1%, and much higher with nucleoside analogs, about 3 to 5%. And mainly if a patient is receiving multiple lines of chemotherapy, then the risk of a myeloid neoplasm increases over time. So we need to be mindful about that. The other risk that I see here with rituximab specifically is the IgM flare. It can happen about 40% of patients when you give rituximab from the get-go. If you delay the entrance of rituximab by giving chemotherapy first and then waiting for the IgM to go down, then that risk goes below 10%. So we tend to do that in patients who have hyperviscosity neuropathy cryoglobulins, in which the IgM is causing the symptom. We start the other treatment first. And once we start getting a response within a cycle or two, hopefully, then we add rituximab at that time. The other option is to plasmapheresis the patient before the chemotherapy is given. So there are a couple of different ways in which this will be done, depending on the clinical presentation on these patients. The other group of treatments that we use a lot in the United States is proteasome inhibitors. And we have borrowed this, obviously, from the myeloma experience. And we do have prospective data with bortezomib, carfilzomib, and ixazomib. And as you can see in these data, the overall response rates in these clinical trials have been between 80 and 90%, major responses between 60 and 70%, and progression-free survivals also measured in several months, between several years, between 4 and 6 years. So as you can see, the efficacy outcomes are very similar to immunotherapy, but there are no formal comparisons between these two. So I cannot tell you that one is clearly superior than another treatment. These are also NCCN endorsed for the use in patients with Waldenstrom's. Now, these treatments will not cause myeloid neoplasms, but they have their own problems. Bortezomib can cause neuropathy, much more manageable now that we're using subcutaneous infusions instead of intravenous injections, and the fact that we're using it weekly rather than twice a week. Carfilzomib can cause cardiopulmonary complications, specifically in patients who are older, so we need to be mindful about that. Ixazomib is not widely available, and it's an oral agent, so that's is more convenient for the patient. The side effects are lower. It can cause a bit of neuropathy as well because it's essentially a pre-drug of bortezomib. It's a pre-bortezomib drug, but the availability and the cost sometimes is more problematic as it is an oral agent compared to an intravenous or other agents. All these treatments can cause reactivation of shingles, so this patient need to be on a shingle pre-treatment with acyclovir or valacyclovir throughout the treatment and for a few months beyond that. So again, we have to also be mindful of rituximab in terms of the flare and start the other treatment first if we think that the IgM is causing the symptoms the patient is having. For the longest time, we were using maintenance rituximab, and this is based on the PRIMA study from follicular lymphoma and some retrospective studies that we did, as well as the Mayo Clinic. But the Germans presented this study, the results of the MAINTAIN study. This is a randomized study in which patients got exposed to bendamustine and rituximab, and only if they had a partial response or better, so minor responses were not included here, partial response or better, they were randomized to rituximab maintenance every 2 months for 2 years or observation. About 109 patients per arm, very nicely balanced. And the data presented showed that there was no benefit on progression-free survival or overall survival by the addition of maintenance rituximab to bendamustine rituximab induction, 6 cycles. Now, in this study, the patients who were older than 65 actually may have benefited from the maintenance compared to patients who were younger. And as I said earlier, patients who had a minor response to bendamustine rituximab were not included in this study. So maybe these patients will also benefit from maintenance. So having this into account, the NCCN now recommends maintenance only if patients had minor responses, maybe superficial partial responses, but with deeper partial response or very good responses or complete responses, we are not using maintenance much more anymore. One point of interest is that this study has not been fully published yet, so we're still waiting for the final report from this study. And then we get into the newer developments in Waldenstrom's, the era of targeted agents. And I think BTK inhibitors have been one of the most important developments in the treatment of patients with Waldenstrom's over the last decade. Ibrutinib, in patients with relapse disease, this study was started in 2012 and published in 2015. That study showed that the overall response rate to single agent ibrutinib, this is 420 milligrams per day, all the way to disease progression or unacceptable toxicity, was associated with an overall response rate of 90%, major responses of 73%, and a progression-free survival at 5 years of 54%. So very competitive with chemoimmunotherapy, very competitive with proteasome inhibitors. Now, additional studies have been done in patients who were rituximab refractory, patients who were treatment naive, in combination with rituximab in the Innovate study compared to rituximab alone. And then we have now the second generation BTK inhibitors that are more specific to BTK, like acalabrutinib. This is a single arm study, and zanubrutinib that actually did a randomized study, the Aspen study, in comparison with ibrutinib. We'll talk about that in a second. But I wanted to just give you a glimpse of the overall response rates with these agents, about 90 to 100%, major responses between 70 and 90%, and progression-free survivals also measured in several years. So again, there are no formal comparisons between BTK inhibitor therapy versus rituximab-containing regimens. They seem to me almost equally effective. But the problem here then is not the efficacy, or at least the decision of treat a patient is not made through efficacy, but rather side effect profile, for example. So these medications will not cause neuropathy. They will not cause a flare on their own. And they are not associated with myeloid neoplasms, but they have a risk of arrhythmias. Ibrutinib, there's a 10 to 15% risk of atrial fibrillation. With acalabrutinib, it's lower to about 5 to 10%. With zanubrutinib, is the lowest, with a rate of atrial fibrillation of less than 5%. Some cytopenias can be seen, specifically in patients who were previously exposed to chemotherapy. The risk of infections goes up a little bit too, and they decreases the response to vaccines. So there are other side effects that we need to be aware with these agents. Another side effect that I wanted to mention is the risk of bleeding. These medications do impact the addition and degradation of platelets, and therefore patients are prone to bleed with trauma or with surgery. So our recommendation is a patient has trauma and is bleeding, the patient should stop the medication. If the patient is going to go for a surgical procedure of some kind, the medication needs to be stopped for a few days before and after to minimize the risk of bleeding. But managing all these side effects have become easier and easier over time with more experience that we have developed with these agents. So the seminal study, the long-term follow-up, was recently published a couple of years ago by my colleague, Dr. Stephen Trion. And it's interesting to see that the genomic profile that we were talking about earlier actually does impact how patients respond to ibrutinib. If the patient has mediated-only disease, the responses are fantastic. 100% response rate, all of them are major, and about 50% of the patients are VGPRs, which are very good responses. CXCR4 mutated patients, their responses are lower, 86%, 70%, and 10% respectively. And if the patient doesn't have the mediated mutation, they can respond, but responses are very superficial. Now, the durability of the response also is distinctive between this group of patients. Patients with mediated-only disease, at 5 years, we have a 75% progression-free survival, which is probably the best outcome you will see in the entire presentation for a relapsed patient. A patient with CXCR4 mutations, the median will be about 4 years. In a patient without mediated mutations or CXCR4 mutations, the median will be less than 2 years. So the depth of response and durability is affected to ibrutinib monotherapy is affected by the genomic profile. But based on this data, the FDA approves ibrutinib monotherapy for patients with Waldenstrom's in 2015. We did a follow-up study in patients who were previously untreated. This is treatment-naive patients for frontline, which I use a lot in my clinic. We published our experience recently in 2022. And as you can see, a response rate of 100% with major response rates into the 90s, and a VGPR about 30%. Patients with CXCR4 mutations had lower response rates, deeper response rates, major response 78 versus 94, and a VGPR of 14% versus 44%. The durability also got affected, and at 4 years, which was the median follow-up in this study, at 4 years, patients without CXCR4 mutations had a 90% progression-free survival, which is outstanding, compared to about 60% if you had a CXCR4 mutation. So we do believe CXCR4 impacts the response to monotherapy ibrutinib in Waldenstrom's. Now, the Innovate study was an interesting study in which ibrutinib was combined with rituximab, and that was compared against placebo and rituximab. And the most recent data, the final analysis was published in JCO in 2022. And as you can see here, all the bars on the left are higher than the bars on the right. And that means the combination of ibrutinib and rituximab is definitely superior in terms of response rates to placebo and rituximab, regardless if you were previously untreated or previously treated, and also regardless if you had any of the different genomic profiles. But interestingly enough, talking about ibrutinib and rituximab, when we think about patients without CXCR4 mutations, the VGPR was 44%. But in patients with CXCR4 mutations, it was 23%. So there was actually a lower rate of deep responses in patients who had CXCR4 mutations, even with the addition of rituximab to ibrutinib. So we just need to have that in mind. Progression-free survival was definitely superior with the combination versus placebo and rituximab. And as you can see here, the progression-free survival was not yet, the median was not yet reached at about 54 months of follow-up versus a median progression-free survival of about 20 months with rituximab alone. And I think I want to emphasize here that rituximab alone is actually a very common regimen used in patients with Waldenstrom's in the United States and outside of the United States as well, despite the fact that it's a suboptimal treatment. As you can see here, this curve really tells us the whole story. The median progression-free survival of 20 months with a response rate between 50 and 60%. And we still, there's a lot of my colleagues using rituximab alone in patients with Waldenstrom's. So I don't use much rituximab alone in patients with Waldenstrom's unless the patient is not a candidate for chemotherapy and is not a candidate for a BTK inhibitor. Otherwise, I tend to use combinations rituximab with rituximab or BTK inhibitors on these patients. Now, a downside of this study was that there was no ibrutinib placebo arm. That would have been ideal to have a third arm with ibrutinib alone, because this study shows me that if I add ibrutinib to rituximab, then I make rituximab better. But it doesn't really tell me what is the role of adding rituximab to ibrutinib. And for that, it would have been great to have this third arm, but it's not there. So we cannot really make a good distinction on which patient benefits from the addition of rituximab to a BTK inhibitor at this time. Acalabrutinib is one of the second generation BTK inhibitors, more specific to BTK. And again, the responses are great. The progression-free survivals at 2 years were great. There has been some long-term data presented at EHA this year. Hopefully that's going to be followed by a manuscript very shortly. The downside of this study, twofold. Number one, it was a single arm study, was no comparisons, and we'll talk about the Aspen study in a second. And also, they didn't look much into CXCR4 mutation testing. And the intermediate mutations testing was done in some patients, but in not all the patients. So we don't have a good understanding of how acalabrutinib works in the different genomic groups that I just mentioned earlier. The Aspen study, on the other hand, looked at many of these other things. So the Aspen study was a phase 3 study comparing zanubrutinib versus ibrutinib. Actually, was one of the first randomized studies comparing two BTK inhibitors head-to-head in any hematologic malignancy, and it happened to be in Waldenstrom, which is nice. So in this study, 100 patients were placed on ibrutinib, 100 on zanubrutinib, and the main objective of this study was to look at VGPR and show that zanubrutinib was superior to ibrutinib in terms of VGPR. It's not the most common outcome that we looked into for phase 3 studies. We usually look at survival benefits, but that's how the study was designed. And at the time of this publication in 2020, the VGPR rate for zanubrutinib was 28% versus 19% with ibrutinib. That 9% difference was not statistically significant, and for that reason, this study is considered negative. As you can see, progression-free survivals, this was up to a 15-month follow-up. There was no major difference between the two groups. And again, the study was not designed or powered to show a difference on that outcome specifically. Where we did see some clinical differences was in the side effect profile. And specifically for AFib, the risk of 15 months with zanubrutinib was about 3% compared to ibrutinib was about 15%. So it was a clear difference in the risk of AFib. And this was recently confirmed in a study in CLL as well. Rashes, infections, and others were much lower with zanubrutinib than ibrutinib. However, the risk of neutropenia was higher with zanubrutinib, but this neutropenia tends to be mild It tends to be transient in most cases, resolves within a few months of therapy. Based on these results and based on this more benign adverse event profile, the FDA approves zanubrutinib in November of 2021 for its use in patients with Waldenstrom's. Now, at ASCO, we had a long-term follow-up. This is with, I think it's 42 months follow-up from the ASPEN study. And this was presented by Dr. Contam from Australia. And you can see here that the depth of response actually gets larger. The responses get deeper over time. And this happens in both groups. So for zanubrutinib goes from 28% VGPR to 33% to 36% at 44 months. In foribrutinib goes from 17 to 20 to 25. So now, obviously, there's apparently a deeper responses with zanubrutinib compared to ibrutinib. But again, the study was not designed to look at this time frame specifically. In terms of progression-free survivals, there seems to be a tiny separation now favoring zanubrutinib over ibrutinib. But again, the study was not powered to show this difference. And in terms of the side effect profile, at the 3-year mark, most of the side effects continue benefiting zanubrutinib over ibrutinib for AFib, for hypertension, for bleeding, and for infections. It seems to have to be kind of equalized in terms of neutropenia, which is expected. I think for these reasons, zanubrutinib has become one of the preferred BTK inhibitors in patients with Waldenstrom's. One downside is that these are 4 pills per day instead of 1 pill per day, but most patients do not seem to mind it. Since there are no formal comparisons between chemotherapy and BTK inhibitor, we did a retrospective study in collaboration with the Mayo Clinic. We put about 300 patients on this. Actually, this is a typo. It's about 125 patients per group. So we did a propensity score match analysis looking at 125 patients with bendamustine and rituximab and 125 patients treated with ibrutinib in the frontline setting. And what we saw is that most of the outcomes were very similar, maybe a little deeper responses with bendamustine and rituximab, specifically in the CR rates, but VGPR, PR, minor responses were also very similar. Progression-free survivals, no major differences, and overall survivals, as you can see here, no major differences either. So I think this supports the notion that any of these regimens are reasonable in a patient with Waldenstrom's, and that the decision to treat or how to treat should be based on a personalized approach. Venetoclax is the most recent addition to the armamentarium in patients with Waldenstrom's. This is a BCL2 inhibitor approved already in the United States for CLL and for acute myeloid leukemia. In this study, we give up to 800 milligrams of venetoclax for 2 years, and then therapy was stopped. These patients were all previously treated, and half of these patients were previously exposed to a BTK inhibitor. 84% response rate with 19% VGPR. This is a very optimistic results. It didn't really matter much if you were previously exposed to a BTKI. Maybe a little bit lower responses if you were prior exposure to BTKI with lower VGPRs, but we could see responses in most patients there. And interestingly enough, no major differences in terms of CXCR4 mutations, maybe a lower VGPR, but the rate of responses were very similar in the two groups. The progression-free survival median was about 30 months. And I want to bring your attention to the curve. As you can see, it goes very well with about 80% progression-free survival until the 2-year mark, in which all patients stop therapy. And this is when we start seeing the relapses. The majority of patients do relapse within the 24 and the 36 mark, which means the year following stopping therapy. CXCR4 didn't seem to matter much in terms of the duration of progression-free survival. So this really tells me that venetoclax is very effective in patients with Waldenstrom's. However, I think we need to understand a little bit better the durability, or maybe in combinations to try to optimize venetoclax therapy. These data prompted the NCCN to actually add venetoclax as a treatment option for relapse patients with Waldenstrom's. Good. Now we're going to talk about clinical trials that I think are very interesting. We are doing a Dana-Farber study combining ibrutinib and venetoclax in patients with Waldenstrom's, and we'll be providing some updates on this study at ASH this year. The other study that also will be presenting some data, publishing some data, is the combination of ibrutinib and And in these patients are patients with Waldenstrom's with MYD88 and CXCR4 mutations. So this is one of the few studies in which the selection of the patient is based on genomics. So some of these data had been presented last year with some early evidence of efficacy. We'll have more data coming up this year. The Canadians are doing a very interesting study with a triplet, essentially combining bendamustine, rituximab, and acalabrutinib. This is called the BROM study. 59 treatment-naive patients will be enrolled in this study. And as you can see, 6 cycles of benda-R, which is standard, with concurrent acalabrutinib, but then acalabrutinib will be stopped at a year. So this study has a number of features that I like personally. Number 1 is a triplet. Number 2, you have a BTKI in there. And number 3, the BTKI is not taken indefinitely. So I think this is a very interesting study, and I'll be looking into these later on. We're trying to open a study at Dana-Farber combining zanubrutinib, bendamustine, and rituximab. So hopefully that's going to be accepted, and we will move forward shortly. As many of you know, patients do become resistant to these covalent BTK inhibitors, and that includes ibrutinib, acalabrutinib, and zanubrutinib, usually mediated by the acquisition of a mutation in BTK, specifically C481S. Now, if a patient develops this mutation on ibrutinib, acala and zanubrutinib will not be effective on these patients anymore. So if a patient is intolerant to ibrutinib, I think they could go into acala or zanubrutinib. But if a patient is progressing on ibrutinib, I don't think acala or zanubrutinib will rescue that patient. And based on this, there's a new group of BTK inhibitors called non-covalent BTK inhibitors that are being developed. Pirtobrutinib is one of them. The other one is called nemtabrutinib. And as you can see here in this study published in Lancet last year by Anthony Matto, we have patients with CLL, mantle cell, Waldenstrom's, and other lymphomas. The dark blue columns are patients who were on a prior covalent BTK inhibitor, and they were progressing on that covalent BTK inhibitor, and then moved into non-covalent BTK inhibitor, pirtobrutinib. And we can see how the majority of those patients who were progressing in a covalent BTK inhibitor actually responded to the non-covalent inhibitor. And there's a study going on in Waldenstrom's, and we're going to be using now pirtobrutinib in combination with other agents in the future for patients with Waldenstrom's. Now, there's a series of selected clinical trials that I put here for your perusal. We do have other triplets in other parts of the country, in the world. Ibrutinib, bortezomib, rituximab is one of them. Ibrutinib, venetoclax, rituximab is another one. Zanu, ixazomib, dexamethasone is another one. And there's a couple of studies in Europe looking at comparing immunotherapy against targeted agents. So ibrutinib, rituximab versus CDR, which is cyclophosphamide, and venetoclax, rituximab versus CDR. So very interesting studies, all being done exclusively in patients with Waldenstrom's. So I think this is very interesting to see. Now, immunotherapy is up and coming. We do have a phospholipid drug conjugate called CLR-131, has been given the breakthrough designation for patients with Waldenstrom's by the FDA. So that's a study that is up and coming. And loncastuximab is an anti-CD19 antibody drug conjugate approved for diffuse large B-cell lymphoma. And my colleague, Sheikh Nasser Roshek in our clinic is running a clinical trial in using these agents for patients who have failed BTK inhibitor and a rituximab-containing regimen. Now, we are in current conversations with Kite to open the ZUMA-25, which will include patients with Waldenstrom's, and we're going to be using CAR T cells, specifically the Brexu cell compounds in patients with Waldenstrom's. So hopefully we'll have that reporting shortly as well. So just some quick conclusions. The diagnosis of Waldenstrom's is established by IgM elevation, LPL infiltration, and MYD88 mutation. We should reserve therapy only for symptomatic patients and leave our asymptomatic patients untreated and monitoring them carefully. If a patient needs to be treated, we have immunotherapy, proteasome inhibitors, BTK inhibitors, BCL2 antagonists, safe and effective. And there are multiple clinical trials coming up with triplets, BTKI combinations, fixed duration BTKI therapy, ADCs, and CAR T cells. So the horizon looks very optimistic for the treatment of patients with Waldenstrom's. And with that, I want to thank you for your attention, and I remain available for any questions you may have. Thank you.
Thank you, Dr. George. That was fantastic. Very, very clear. And you updated us with all aspects of Waldenstrom. So we have some of our colleagues here, and I'm sure that they will be interested in asking you some questions. Anyone of you can please go ahead. So Dr. Bhau said, you can go ahead and ask the question directly. He has put a question in the chat box and he's here. So how do you approach rising IgM in a patient post-treatment? Do we need to check mid-88 or CXCR, especially later at progression needing treatment? Then there are other questions.
Yes, so let's go one by one. So how do you approach rising IgM in a patient post-treatment? So there are two ways, right? Number one, we do have patients who got fixed duration, right? Benda R or bortezomib R or cyclophosphamide R, and you give them these patients 6 cycles, and the patient just is monitored. If the patient is being monitored off therapy, right, just being monitored without any specific treatment being given to these patients, I think we can continue watching the rise in IgM as long as the patient is asymptomatic. So how do we define progression? We take the lowest IgM the patient has. Let's say a patient started with a 4,000 IgM, got down to 1,000 on therapy, which is a partial response, and then sustains the 1,000. Progression will be defined once it's 500 points higher than the lowest level ever. So 1,500 or higher will be disease progression. So that will be, by definition, what we will do. But the large majority of patients are asymptomatic at the time of disease progression. So we don't have to immediately treat just because the patient has progressed, which is different than myeloma. In myeloma, we treat immediately, right? Even with just a whiff of disease progression, most of the time we're actually treating those patients. But in Waldenstrom, we do a little bit different. So we wait, and the IgM will go up again. And will go up slowly. Actually, it takes years in most cases to go from disease progression to actually need therapy. So we go back to our criteria to consider therapy: symptomatic anemia, symptomatic hyperviscosity, symptomatic neuropathy, symptomatic extramedullary disease. So we wait until those symptoms do start. I mean, we don't have to wait until the patient is very symptomatic, but it's reasonable to wait as long as the patient is reasonably asymptomatic before we actually treat. Now, that's with the treatments that are fixed duration. Now, if a patient is on indefinite duration, like ibrutinib, for example, so somebody takes ibrutinib, 4,000, goes down to 1,000, and then at some point the IgM starts rising while the patient is taking ibrutinib, then that's a little bit more difficult because we don't really know when is the right time to treat those patients. If we treat the patient just because of the IgM increase, that's too early. Because we have in clinical trials experience in which patients have taken ibrutinib for years. When the IgM has gone up a little bit and you continue taking ibrutinib, they continue benefiting from the ibrutinib therapy despite the fact that the IgM is going up as long as they are asymptomatic. The problem is when the patient meets criteria to treat, let's say the hemoglobin is 10 and the IgM is 5 or 6,000, and then you want to stop the ibrutinib to give the next treatment, the disease usually rebounds. And that's the part that is problematic. So I don't think we should treat at the time in which the IgM goes up. That will be too early. But I don't think we should wait all the way until the patient is symptomatic, as we do with chemotherapy, because the disease tends to rebound at the time, and the patients tend to be very, very symptomatic from that. So when there is the right time, and we don't know that. I don't think we know exactly when is the right time to switch, and stop the BTK inhibitor and move to the next treatment. What I do in my clinic is if I see a decline in the hemoglobin of at least 2 points or 3 points, that's enough for me. So if the patient is a hemoglobin of 14 and then it's 13, 12, 11, and the IgM is going up, then I tend to, look at that. I tend to look at the IgM before the BTK inhibitor was started. So the patient, let's say the patient started at 4,000 and then got down to 1,000, and then the IgM is going up and it crosses the 4,000 again on ibrutinib. Even though the patient is asymptomatic, I might consider therapy at that time. But again, all these are not based on science. There is no based on prospective studies. We do not know when the right time to switch on a BTK inhibitor is. I just know that the IgM alone is too early, symptoms is too late. And someplace in the middle is probably the right approach. And that has to be very personalized from patient to patient. The question is, do we need to recheck for MYD88 or CXCR4 later at progression needing treatment? My practice is to recheck for MYD88 and CXCR4 at each and every progression time in which the patient needs to be treated, but that's an academic approach. In the community, I don't think if you have these data already, I don't think it's necessary. So, for example, with TP53, you see in CLL, right? You see how the proportion increases over time, right, in patients. But we don't have those data in CXCR4. What we think we know is that the patients are MYD88 right from the get-go, or MYD88 in CXCR4 right from the get-go. So it's not like because you treat, then you acquire CXCR4 mutations. I don't think that's what we are seeing. We're seeing CXCR4 mutations right from the start. And I think that makes a little bit different. This is a different approach. So if you already have this data, I don't think you need to do it in the community, and you don't need to repeat it. But if you don't have this data, then I would recommend getting them if you can. Now, MYD88, I think, is easier PCR to establish PCR, as CXCR4 is a bit more challenging to obtain, specifically in the community, even in the United States. You know, MYD88 is done by, I think, 90% of practices in the entire country, but CXCR4 really only a minority of centers run it, and most centers are academic centers, not really community centers. So the CXCR4 testing has not really coming up to speed. It's just so difficult to test for it. And I think in the clinic you don't have to precisely test for that if you don't want to, but if you are suspecting it, you want to, then the hyperviscosity patients, the patient with coagulopathy, that will be the patients that more likely will have a CXCR4 mutation. Comments on transformation, if there's a difference in the treatment received. Transformation can occur at any time. We do have a number of studies from France and us that actually showed that you can have transformations even if you have not been treated for the Waldenstroms. You can have transformations when you're responding to bendamustine and rituximab on the Waldenstrom. The Waldenstrom is getting better, and then the patients transform. So transformation can occur at any time. I don't think there's one treatment that increases the risk of transformation. There is one study that we published years ago, kind of blaming fludarabine a little bit, but since we use it less and less, I don't know if it's something that really is relevant or not. So the transformation can occur at any time, and we need to treat those patients as diffuse large B-cell lymphomas. So if the patient has never been exposed to an anthracycline for the Waldenstroms, which most patients don't at this time, then we treat them with R-CHOP or R-EPOCH, depending on the practices you follow for diffuse large B-cell lymphoma.
Right. Can I ask you one question? So if somebody is off treatment after, say, bendamustine, rituximab, and when the treatment has to be restarted, will you invariably go for a BTK inhibitor, or there is a place for same chemoimmunotherapy or a different chemoimmunotherapy? And what should be the remission duration for which repeating a chemoimmunotherapy?
Yeah, no, that's a great question. Specifically in places in which, where there's some more limited access to targeted agents, I think, what we have is chemotherapy, and that's what we will use. So I really don't have too much trouble retreating patients with cyclophosphamide, for example. But retreating patients with bendamustine, I'm a little, doubtful about that. Actually, I was considering that in a patient of mine who had like 9 years of benefit from bendamustine and rituximab, and I actually reached out to Dr. Christian Buski, from the German group. I mean, if anybody knows bendamustine, it's the Germans, right? So I reached out to him, and he was like, "No, we don't do that." So even the Germans don't re-expose their own patients to bendamustine, and I think the concern is the stem cell damage and the risk of myeloid neoplasms. So I would say if you get very well over 5 years, then I think considering the treatment again is reasonable. The things that the treatments that you can retreat without too many concerns is actually protein inhibitors. If you got bortezomib rituximab and you get 5-6 years from it, I think you can really try bortezomib rituximab again. The same with carfilzomib, the same with ixazomib. So I think with protein inhibitors, the retreatment scenario is much more reasonable compared to chemotherapy. So I do not immediately go into a BTK inhibitor. I would say most patients prefer the idea of a BTK inhibitor. There are actually patient-reported outcomes data recently published that shows that patients on BTK inhibitors have a much better quality of life overall than patients who undergo chemotherapeutic agents or intravenous treatments, for example. So a lot of our patients like that idea, and that's why they go for BTK inhibitors. But yeah, we have some patients who tell me, I don't want the pill. I don't want the pill at all. I want to be treated with finite duration treatments. And in those patients, I tend to do bendamustine, I tend to do bortezomib, cyclophosphamide, and other treatments along the way.
And will you say that bortezomib or any PI-based treatment is a relatively weaker treatment?
I would say probably. As we don't have a randomized study, right? I cannot tell you that it is. In my experience, I think probably, but it all depends what you want to achieve, right? For example, if I have a 45-year-old gentleman, right, who doesn't want to be on a pill forever because he's 45, and they want to get exposed to chemotherapy because of the myeloid risk, then it's a patient that a PI treatment will be very reasonable, and we do have, median progression-free survivals, in the 4 or 5 years with protein inhibitors. So, I use it. I don't say I use it very often, but there's a group of patients in whom I do consider protein inhibitors.
And if in a rituximab exposed patient, will you use that again and again, or you just give a BTK inhibitor, no rituximab?
So, so if a patient has gotten rituximab before, let's say in combination, right, with bendamustine, then I use it again in combination with bortezomib. I think there's something about the synergistic benefit of adding an anti-CD20 antibody to either chemotherapy or protein inhibitors. The only time I do not do rituximab again is if the patient is intolerant to rituximab, right? If the patient has gotten to a point in which the infusions of rituximab are inducing severe infusion reactions, then that's a time in which I would say, probably not a good idea to try rituximab. In that setting, we used to do a lot of ofatumumab, which is a fully human antibody. But right now this has been taken out of the market a little bit, so the accessibility is a little bit more problematic. We don't really have a lot of data with obinutuzumab, which is a humanized antibody. There's a study going in Poland as a single agent, but I don't know what the outcomes are of that study yet. I don't think anything has been published or presented. So yeah, I mean, I have tried obinutuzumab in a couple of patients, and that has worked well. So I think if a patient is intolerant to rituximab, I will try maybe obinutuzumab in combination with whatever you want to use later on. But yeah, so based on the follicular data, we know if we use rituximab alone and then rituximab alone, at some point the patient becomes refractory to rituximab. So, and that's why, I prefer to combine it. And for all the reasons I exposed during the presentation, I prefer to combine it. And if somebody's intolerant, then I try a different antibody.
One more question in the box is about the role of MRD.
Yeah, I'm jealous of my CLL in my myeloma colleagues, right? They're talking about MRD, 10 to the 4, 10 to the 5, 10 to the 5.5. We don't even get to CRs. I mean, if you saw the data that I presented, I really didn't mention CRs at all there. The retrospective study from the Mayo Clinic showed a 20% CR with bendamustine and rituximab, but I mean, I'm very skeptical of that. The reason I am, even though I'm an author on the paper, but even the reason I'm skeptical is because in the prospective studies, which they are much better designed and defined, in the Maintain study, for example, that was presented at ASH by the Germans, the CR rate was 6% to bendamustine and rituximab, 6%. And if you look at the proteasome inhibitor data, I think the CR rate is less than 5% in all the papers that have been published. And if you look at the BTK data or the BCL2 data, no CRs have been in prospective studies have been published from these studies. So we still have not gotten to a substantial CR rate for us to even talk about MRD, to be honest. So we need to get to CRs first. And the main problem is getting rid of that residual IgM M spike. It doesn't go away for some reason. So, that's what we're looking into, bispecifics, maybe looking into CD19, BCMA, trying to see how do we target the plasma cell compartment a little bit better. We tried to do it with daratumumab, but it didn't really induce very deep responses to begin with, despite the fact that in amyloidosis and myeloma it works very well. In Waldenstrom didn't work so well. So we're still in that struggle. I think one of the big unmet needs in patients with Waldenstrom's is that we cannot get yet to substantial CR rates.
Thank you. Dr. Reshma, your question.
Excellent presentation, doctor. My question is, so if we see a patient, because we are working in India with the limited resources, most of the patients don't prefer continuous therapy. So BTK is not a very common option for us. So if a patient comes to you, will you prefer Bortis-based or bendamustine rituximab-based?
Yeah, so I mean, again, in situations like this, I would either consider bendamustine and rituximab, which is, I would say, my preferred regimen for a fixed duration regimen. So unless there is a clear contraindication or an aversion of the patient to receive chemotherapy, then I will do either bortezomib, rituximab, for example. But again, we did a retrospective study, and again, it's retrospective at the Dana-Farber, in which we actually compare BDR, bortezomib plus rituximab, versus bendamustine and rituximab. And really, the outcomes were very similar in terms of responses, PFS, and overall survival. So now, if you adjust for other factors, then bendamustine and rituximab has a little bit of an edge over bortezomib and rituximab, but not that bortezomib and rituximab is not effective. So, I would say I would prefer benda-R. If there are specific reasons the patient doesn't want to, is not a good candidate, then I will go for bortezomib and rituximab, and I would not really be too concerned about that.
And do you modify the dose of bortezomib because of the concern for neuropathy, since the patients may have neuropathy at presentation itself?
Yeah, so if the patient has neuropathy, I try to avoid bortezomib on these patients. However, we do have some data showing that even if you have neuropathy and you get exposed to bortezomib, if you respond, actually the neuropathy gets better, because it's a different mechanism of action. And if you're using the bortezomib subcutaneously and once a week, then the risk of neuropathy is much, much lower. It's actually less than 10% compared to 40% if you give it intravenously twice a week. So I think there's some benefits to it. I prefer to avoid it. So when I use chemotherapy, when I treat a patient with neuropathy, I try to use either CDR, cyclophosphamide, or bendamustine, or a BTK inhibitor. I try to avoid bortezomib. I can use carfilzomib in those scenarios too, but I agree, it's not ideal. But if it's the only option you have, going in once a week, subcutaneous, it could potentially work for the neuropathy as well.
Thank you. Thanks so much.
Thank you. Dr. Shilpa.
Thank you, doctor, for a wonderful presentation. My question here is that we have seen that there are good responses to like MYD88 mutated variant response ideally to the ibrutinib. So is there a benefit of trying chemotherapy based regime for those unmutated variants, or do you still prefer using BTK inhibitors, although you have told that it is a personalized choice of using BTK? But I was just thinking whether this is a possible scenario.
Yeah, so I mean, in my clinic, I don't use only BTK inhibitors. I use a little bit of everything. But yeah, specifically for patients without mediated mutations, then I try not to use BTK inhibitors in those patients. I try to use bendamustine, cyclophosphamide, even bortezomib. Now, there's some data with Acala and Zanu in patients who do not have mediated mutations showing efficacy. The problem is, in those studies, the mediated testing was not as deep as we do at Dana-Farber. So I suspect that there are some patients who were labeled mediated negative, but they actually have the mediated mutation, just a very low burden. So in my practice, I try to expose patients to other treatments that are not BTK inhibitors. Now, if I need to use a BTK inhibitor because there's no other options left in these patients, I usually add rituximab to the BTK inhibitor in that specific setting.
Thank you.
Dr. Akshay.
Thank you, sir, for the great presentation. So my question is, what is your opinion for the use of soluble CD27 as a marker of disease burden and as a predictive marker of IgM flare? And should this test be routinely done?
That's a great question. That's actually, data from Dr. Trion's laboratory. We don't use it routinely. I think that was more of a research test. I think, per se, it didn't catch up really in terms of how to use this. And now that we have few ways in which how to prevent the flare, right? Either by plasmapheresin first or by treating with the chemo first and then delaying the introduction of rituximab. I think the whole soluble CD19 scenario has not really something, is not something that we use routinely.
Thank you. Dr. Amrita?
Thank you, Dr. Castillo. Actually, you've answered most of whatever questions I had. You've answered them pretty effectively. But however, just for the practical purposes, I wanted to know if somebody's presenting to you with symptomatic hyperviscosity, what would be your preferred schedule for plasmapheresis? I mean, would you do it on alternate days or would you do it daily, and for how long would you continue it?
Yeah, that's a great question. So what I do in my practice, and again, there's no data on this, so you can do, many different things. So what I do in my practice is I do 3 plasmapheresis in 1 week. So basically Monday, Wednesday, Friday, for example. But I start the treatment, right after the last, plasmapheresis. So with 3 plasmapheresis, you guarantee that at least you have a decrease on the IgM by at least 60 to 70%. That's, something that we published. So by doing that, you take the patient out of the plasmapheresis area. The patient is asymptomatic. It's going to take 4 to 5 weeks for the IgM to go back up again. So we need to be mindful about that. So we basically do the plasmapheresis, and then we immediately start treatments right there. If we're starting ibrutinib, we start right from the start. If we're going to start bendamustine and rituximab, we start after the last plasmapheresis. Otherwise, you're going to be kind of removing, what you just introduced. So, and then hoping that within those 4 weeks, the medication is going to start working, so you don't have to plasmapherese again. But it might happen that the IgM can go up again, and you might need to plasmapherese at some point in the future, maybe one more time, to make sure that you keep the patient, out of the hyperviscosity range. So I wouldn't stop therapy just because I gave 1 cycle and the IgM went back up again. I mean, it's bound to back up again. So we need to be mindful of that. So we use plasmapheresis accordingly. So in some scenarios, in most scenarios, I start with 3, in 1 week, and then I continue doing 1 every 2 to 3 weeks until the patient gets into the response that I would like.
Okay, wonderful. And then is it a routine practice to check for fibrinogen levels, or do you just use a human albumin solution? And do you check for coagulopathy if you're doing regular plasmapheresis?
I typically don't, and mainly the reason for that is because, we use it just the 3 times. In most cases, that's all we need. We don't really worry much about this. I think the people who run into these coagulopathy issues because of the plasmapheresis are the patients who are having plasmapheresis, very frequently, much more than 3 times, So I think those are the patients that are running into trouble with this. Otherwise, I do not check unless there's a clear reason in which I'm concerned the patient has a coagulopathy, which can happen with hyperviscosity. And then I check, PT, INR, I check von Willebrand, factors, but I do not do it just because I'm doing a plasmapheresis on the patient.
Okay, thank you.
Few questions. One is a very basic question. What are the steps you take for increasing the sensitivity of picking up MYD88? Some very basic things which will, often we get the result negative, and I think we're missing it.
Yeah, so I think there's a couple of issues there. Number one, it all depends on the quantity of disease that you have in your marrow. If you have more than 20%, I think it's probably a real negative value. But if you have 5-10% disease in the marrow, that could be a false negative. So we need to be careful about that. And number two, we need to see, what type of test is being used. If you use PCR, that's has more depth. But if you use NGS, that has a little bit less depth. So, we need to play around with those different values. So if somebody has 80% disease and the PCR is negative, I would say that probably is a real negative PCR.
Okay. The other thing is about venetoclax. We have very little experience of using venetoclax in this disease. So where exactly do you place it? It's the last modality of treatment. Are there any predictors of response? Do you use it as a monotherapy? It's just like a, sort of palliation at the end. Where do you place it?
Yeah, so we use it as monotherapy as this time, and we typically use it as a third line. Somebody who got already chemotherapy, rituximab, then BTK inhibitor, then we tend to use BCL2 inhibitor after that. But again, I think we need more studies to actually make it more effective, optimize it. I think combinations make sense, and I think that's what's up and coming.
you feel it's a very powerful drug and it will come forward, or it will remain as the last line?
Yeah, I think it's very powerful. We just need to understand a little bit better how long we need to give it for. And I think in the combinations, I think it's going to shine even better in combinations. We're trying to combine it with ibrutinib, as you know. We're trying to combine it with antibodies, right? So I think all that is going to make it a more powerful agent that is easy to use because it will not be an indefinite duration treatment.
And it has been easy to continue 800 mg, or you have to drop the doses?
I mean, yeah, 800 is a little too high. I mean, in my experience, you know, in the clinical trial, people took it, but nowadays that I'm studying patients on venetoclax, I'm actually doing 400 only, you know, of clinical trials, and that seems to work very well too.
And are you concerned here about tumor lysis? You have to ramp up, or you can go with full back?
Yeah, it's rare in Waldenstrom's, but again, if somebody has a big spleen, big lymph nodes, then we need to make sure that we monitor those patients very carefully, that we give them a lot of fluids, that we measure for tumor lysis over the first 24 hours to make sure that doesn't happen. So far, out of 100 and some patients that we have treated, we have had 2 laboratory tumor lysis. We have not had clinical tumor lysis, you know, patients.
And are they a predictor of response?
And at this time, we don't have that understanding very well. You know, I think the prior exposure to BTK inhibitor is one predictor. I think if you had more than 3 lines of treatment before exposure is another predictor of a lower response. And that's pretty much all I can think of at this time.
Dr. Mona, your question.
I want to apologize, but I need to get going. So this will be the last question, if that's okay.
Yes.
I'm so very sorry. Thank you.
Yes, sir. Thank you, sir. Sir, I just wanted to ask that we usually sense a mid-88 mutation, but we don't have CXCR4 mutation testing, sir, usually. So how can we choose the upfront ibrutinib in this scenario, sir? In which patients, if we don't have that CXCR4 mutation?
Yeah,
Yes.
so that's a great question. So what I do, you know, and what I do is actually, if I decide that I'm going to give a patient a BTK inhibitor, I actually do start the BTK inhibitor first. And if the patient responds, you know, within 3 months with a very nice deep response, I had already a PR within 3-4 months, I don't even need to add the rituximab. But if the patient is not responding as fast as I thought it was going to respond, is responding but not great, 4 or 5 months, you're getting to the 6 months and you're not getting to a PR yet, then that patient very likely has CXCR4 mutations. I mean, this is kind of a, you know, an approach, a clinical approach. And at that moment, what I'm doing is I'm adding the rituximab at that time. You know, so that's the way I'm doing this in my clinic. It's not ideal because there's not a lot of data supporting that approach, but that's what I tend to do. So when I do that, even though I know that 30% of my patients will have CXCR4 mutations and will have lower responses to ibrutinib, actually I add rituximab maybe in just 15% of those patients, because there's a group of patients with CXCR4 mutations, the frame shift mutations, that will respond very well to ibrutinib. So only the nonsense mutations are the ones that don't respond very well to ibrutinib. So that's one way to kind of differentiate one from the other, and then add the rituximab in a more reasonable manner.
Okay, thank you so much, sir.
My
Thank
pleasure.
you, Dr. Castillo. We have Dr. Manoj here to give the official vote of thanks.
Sir, you were being wonderful and you are heard. You must listen to this, sir. You are heard in India, Kenya, Nepal, Bangladesh, UK, Philippines, Myanmar, Sri Lanka, Malaysia, USA, Indonesia, Pakistan, Lithuania, New Zealand, Abu Dhabi, Australia, and Poland. That's what
Amazing.
you did.
That's amazing.
You have a wonderful day, sir. Thank you for your time.
Thank you very much. Everybody has a nice rest of the weekend.
Thank you for being
you.
with us. Thank you.
Thank
Take
you,
care.
Professor Agrawal, sir, and all the discussants today, Dr. Reshma, Dr. Govind, Dr. Advait, Dr. Prantar, Dr. Shilpa, Dr. Amrita, Dr. Mona, Dr. Bhausao, Dr. Akshay, and Dr. Aditya. Thank you for your questions. Really appreciate. And all of you, please don't forget 11:30 tomorrow.
Thank you, Dr. Manoj, for supporting us. Bye-bye.
Thank you. Bye-bye.